In order to properly osmose new information, your brain is protected from the rest of the body by 3 meningeal layers. From outside to inside, they're the dura mater, arachnoid matter, and pia mater, with cerebrospinal fluid in the space between the arachnoid and the pia. If pathogens make their way into these layers, the inflammatory response results in meningitis. If they find a way to penetrate into the brain parenchyma itself, the inflammatory response results in encephalitis. And if a pathogen walls itself off, it's called a brain abscess. Meningitis can be caused by viruses, bacteria, including mycobacteria like TB, fungi, and parasites. When it's caused by viruses, tuberculosis, fungi, or parasites, it's called aseptic meningitis, because routine bacterial cultures
Meningitis can be caused by viruses,
bacteria,
sometimes
mycobacteria,
the infection may
like
spill
TB,
over from the
fungi,
meninges
and parasites into the brain parenchyma, and that's called meningoencephalitis. Now, the most common causes of acute bacterial meningitis depend on the individual's age. For example, in infants less than 3 months old, the most common causes, in a descending order, are Group B streptococci, Escherichia coli, and Listeria monocytogenes. In adolescents 13 to 17 years old, the most common causes are Neisseria meningitidis, followed by Streptococcus pneumoniae, and Haemophilus influenzae. In non-adolescent children 3 months to 12 years, and in adults, Streptococcus pneumoniae is the most common cause, followed by Neisseria meningitidis and Haemophilus influenzae. It's also important to consider Listeria monocytogenes in adults over the age of 50, or those who are immunocompromised. Also, Staphylococcus aureus is more common in individuals with a history of neurosurgical procedures or trauma to the head. Other less common but extremely important bacterial causes include Mycobacterium tuberculosis, Lyme meningitis, Rocky Mountain spotted fever, and neurosyphilis. These are separated from the other causes because they're usually associated with a specific risk factor. For example, tuberculosis meningitis occurs in individuals with a history of exposure to tuberculosis, oftentimes infants living in endemic areas. Lyme meningitis is caused by the spirochete Borrelia burgdorferi, and individuals may have a history of travel to an endemic region like the northeast of the United States. Finally, Rocky Mountain spotted fever is caused by Rickettsia rickettsii and is carried by the dermacentered dog tick and is endemic to Central and South America, as well as the southeastern United States. Neurosyphilis is rare, but it can arise in sexually active individuals with a history of untreated syphilis, especially in immunocompromised individuals. Now, viruses can cause aseptic meningitis, meningoencephalitis, or pure encephalitis. Pure encephalitis without meningitis is usually caused by viruses. The most common cause is a group of viruses called enteroviruses, like echovirus and Coxsackie virus. From their name, we know that these viruses make their way into the body through the intestines. Herpes simplex virus, or HSV, is a very important cause of meningoencephalitis. Other viruses include arboviruses like West Nile virus, which uses a mosquito vector. Although mumps is quite rare due to vaccination, in unvaccinated individuals it can cause viral meningitis as well as encephalitis. Measles can cause encephalitis in the acute phase of the illness. However, even after the acute infection has resolved, a form of encephalitis called subacute sclerosing panencephalitis, or SSPE, can appear up to 10 years later. Varicella-zoster virus, or VZV, can cause a life-threatening form of encephalitis, particularly in immunocompromised individuals. When it comes to fungi, Cryptococcus is an important cause, particularly in HIV-infected individuals with a CD4-positive T-cell count below 100. Additionally, Coccoides immitis is a potential cause of fungal meningitis, especially in the southwestern United States. As for parasites, a particularly fatal form of meningoencephalitis is caused by Naegleria fowleri, its primary amoebic meningoencephalitis. This organism is called the brain-eating amoeba, and it's usually acquired from fresh water. It makes its way to the brain through the nasal passages, like when someone dives into water and it rushes up through the cribriform plate. A dangerous complication of malaria is cerebral malaria, a type of meningoencephalitis. Finally, it's important to remember that the same pathogens that can cause meningitis can also cause meningoencephalitis. Alright, now all forms of meningitis present with a triad of fever, neck rigidity, and headache. Other common symptoms include photophobia, nausea, and vomiting. The difference is in the time course. Acute bacterial meningitis and HSV meningoencephalitis usually present within hours to a few days. Viral meningitis, cryptococcal meningitis, Lyme disease, and Rocky Mountain spotted fever usually present over the course of days to weeks, while tuberculosis, coccidioides, and syphilis tend to present over the course of months. What distinguishes pure encephalitis from meningitis is an abnormal brain function, like a change in behavior and personality, and the absence of meningeal irritation symptoms like neck rigidity. Seizures can occur in both meningitis and encephalitis, and both can eventually lead to an altered mental status and even a coma or death. Importantly, infants can present more subtly with irritability and poor feeding. Additionally, some clinical clues on physical exam may point towards a specific cause. For example, petechiae are characteristic of Neisseria meningitidis. A red maculopapular rash on the wrists and ankles that spreads towards the body may indicate Rocky Mountain spotted fever. A bullseye-appearing rash called erythema chronica migrans, bilateral facial nerve palsy, or cardiac arrhythmias like atrioventricular node block point towards Lyme meningitis. Flaccid paralysis of the extremities is characteristic of West Nile virus, which occurs because the virus may also cause a concomitant myelitis, which is an inflammation of the spinal cord. Parotitis may suggest mumps, and a group of vesicles in a dermatomal distribution suggests VZV. Features of disseminated tuberculosis like pulmonary infiltrates, lymphadenopathy, and a positive tuberculin skin test should prompt consideration of tuberculosis meningitis, especially in infants. Also, on examination, resistance to flexion of the neck indicates neck rigidity. And fundoscopy of the eye can reveal papilledema, which indicates an increased intracranial pressure. Sometimes, there may also be focal neurological deficits like cranial nerve, motor, or sensory deficits. Helpful signs include the Kernig and Brzezinski signs. To elicit the Kernig sign, place the individual in a supine position. Then, flex the hip to 90 degrees and attempt to extend the knee. If the individual has pain with full extension of the knee, that's a positive Kernig sign. To elicit the Brzezinski sign, you have to passively flex the neck, and if there's involuntary flexion of the hips due to pain, that's a positive Brzezinski sign. A helpful way to remember these signs is that Kernig starts with K, like knee, and Brzezinski starts with B, like back of the head. Now, these signs aren't particularly sensitive, so negative Kernig and Brzezinski signs don't exclude meningitis. When meningitis or encephalitis is suspected, it's important to first identify any risk factors for increased intracranial pressure, because increased intracranial pressure is a risk factor for cerebral herniation, precipitated by a lumbar puncture, and that can be lethal. The risk factors include papilledema, a focal neurological deficit, prior history of a tumor or stroke, an abnormal level of consciousness, new onset seizure, or being immunocompromised. In individuals without any of these risk factors, the lumbar puncture is done right away without needing a CT scan. After you've obtained the cerebrospinal fluid sample, you can obtain blood cultures and then start IV dexamethasone and empiric antibiotics. The logic behind giving IV dexamethasone before IV antibiotics is that it reduces the inflammatory response that usually occurs when antibiotics destroy bacterial cells. Steroids decrease mortality and the risk of complications like hearing loss, cranial nerve palsies, and seizures, particularly from Streptococcus pneumoniae, as well as Haemophilus influenzae in children. So, if these pathogens are suspected or found on the gram stain culture, then dexamethasone is continued for 4 days. If not, the IV dexamethasone is stopped. In addition to empiric antibiotics, if the individual has features of encephalitis, such as the presence of abnormal brain function in an adult, or fussiness or lethargy in an infant, or temporal lobe enhancement on CT scan, then empiric intravenous acyclovir should be added because it's crucial to not delay treatment if herpes simplex encephalitis is a possibility. If the individual does have one of the risk factors of increased intracranial pressure, then blood cultures are obtained, IV dexamethasone is given, and then 15 minutes later IV antibiotics are started, along with IV acyclovir if herpes simplex encephalitis is suspected. After that, a head CT is obtained, which can identify any mass lesions which might cause the symptoms of an increased intracranial pressure. The head CT might also show some helpful clues. For example, herpes simplex encephalitis commonly causes temporal lobe enhancement, and tuberculosis meningitis often involves the brainstem. So if the CT scan is normal, then the lumbar puncture can be done safely. There are 5 key things that are looked at in cerebrospinal fluid: opening pressure, white blood cell count and differential, protein level, glucose level, and gram stain and culture. These can help differentiate between normal CSF and a bacterial, viral, fungal, or tuberculous cause of meningitis. Now, normally the opening pressure is below 200 millimeters of water, and only up to 5 white blood cells are present per cubic millimeter. 70% of those white blood cells are lymphocytes, 30% are monocytes, and very, very few are neutrophils. Normal cerebrospinal fluid protein levels range between 15 to 50 milligrams per deciliter, and glucose levels are usually between 45 to 100 milligrams per deciliter. The glucose in cerebrospinal fluid is often 2/3 of that in the serum. Now, the opening pressure is usually over 200 millimeters of water in all forms of meningitis. There's also an elevated white blood cell count in the cerebrospinal fluid called pleocytosis, and it's usually in the thousands in bacterial meningitis, and in the hundreds in viral, fungal, and tuberculous meningitis. A predominantly neutrophilic pleocytosis, over 80% neutrophils, indicates bacterial meningitis. A predominantly lymphocytic pleocytosis, over 50% lymphocytes, may indicate viral meningitis, and a predominantly mononuclear pleocytosis, over 50% monocytes, suggested tuberculous or fungal meningitis. The protein level ranges between 100 to 500 milligrams per deciliter in bacterial and tuberculous meningitis. There may be between 15 to 200 milligrams per deciliter in viral and fungal meningitis. That's because there's more inflammation in bacterial and tuberculous meningitis, which disrupts the blood-brain barrier and allows proteins to go from the plasma into the cerebrospinal fluid. The glucose level is usually below 40 milligrams per deciliter in bacterial, tuberculous, and fungal meningitis. Additionally, the ratio of cerebrospinal fluid glucose to serum glucose is usually below 0.4, and in neonates it's below 0.6. On the other hand, glucose levels and its cerebrospinal fluid to serum ratio is normal in viral meningitis. The reason for this is because inflammation secondary to bacteria or fungi blocks glucose from entering the cerebrospinal fluid through glucose transporters. Alright, now in bacterial meningitis, the gram stain result can be done immediately, whereas the culture can take up to 5 days, although most pathogens grow within 48 hours. So if the culture is negative, then this effectively rules out acute bacterial meningitis. Unfortunately, the yield is significantly decreased if antibiotics are given before collecting the cerebrospinal fluid. When it comes to viruses, tuberculosis, fungi, and neurosyphilis, specific tests may be obtained. In tuberculous meningitis, the stain would show acid-fast bacillus and cultures can take weeks, although the yield is low. Therefore, TB PCR is preferred because it's faster and more sensitive. If cryptococcal meningitis is suspected, an India ink stain is obtained on the cerebrospinal fluid, which shows broad budding yeast and a thick fungal capsule that does not take up the stain. However, the more sensitive cryptococcal capsular antigen test has taken over and is more commonly used. In coccidoidal meningitis, microscopic examination of the cerebrospinal fluid may reveal small spherules. However, serum serology is the mainstay of diagnosis. Due to the advent of penicillin, neurosyphilis is extremely rare. However, if suspected, a venereal disease research laboratory, or VDRL test, as well as a rapid plasma reagin, or RPR test, can be obtained on the CSF. To look for viral meningitis, PCR for HSV, enteroviruses, and in some cases VZV can be done. Also, the presence of red blood cells in the cerebrospinal fluid suggests herpes simplex encephalitis. Additionally, if West Nile virus is suspected, then a serology of the cerebrospinal fluid is obtained for the West Nile virus IgM antibody. In the right clinical context, PCR for other viruses like measles, mumps, or influenza may also be obtained. Finally, since pure encephalitis is mainly caused by viruses, the same viral investigation sent for meningitis can be sent in those individuals. Empiric treatment of meningitis depends on an individual's age. In an otherwise healthy adult, intravenous third-generation cephalosporins like ceftriaxone or cefotaxime plus vancomycin is the regimen of choice. The cephalosporin adequately covers Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. Vancomycin is added because of the increasing prevalence of penicillin-resistant pneumococcal infections and methicillin-resistant Staphylococcus aureus. If the individual is over 50 years old or immunocompromised, then ampicillin should be added to cover Listeria monocytogenes because Listeria is resistant to cephalosporins. If an individual has a severe allergy to beta-lactam antibiotics, then in addition to vancomycin, moxifloxacin is given in place of the third-generation cephalosporins. Infants under 3 months of age are typically given intravenous cefotaxime, vancomycin, and ampicillin. Ceftriaxone is avoided because it can cause cholestasis in infants. If a specific pathogen is strongly suspected or identified, treatment is tailored to that pathogen's susceptibilities. Typically, Neisseria meningitidis and Haemophilus influenzae are treated for 7 days, while Streptococcus pneumoniae is treated for 10 to 14 days. Interestingly, because Neisseria meningitidis is transmitted in respiratory droplets, people in close contact with individuals should receive antibiotic prophylaxis. Rifampin is classically used, but ciprofloxacin and ceftriaxone are also good options. Staphylococcus aureus, gram-negative bacteria, and Listeria are treated for a total of 21 days. Lyme meningitis and Rocky Mountain spotted fever are both treated with doxycycline. Neurosyphilis is treated with intravenous penicillin for 10 to 14 days. Tuberculous meningitis is treated with the RIPE or RIPS regimen, which includes rifampin, isoniazid, pyrazinamide, and either ethambutol or streptomycin for 2 months, followed by 10 more months of isoniazid and rifampicin. Additionally, corticosteroids like dexamethasone are used in these individuals. When it comes to viruses, empiric acyclovir is continued until the PCR results confirm HSV encephalitis. Additionally, if VZV meningitis or encephalitis is confirmed by PCR, treatment includes the antivirals ganciclovir or foscarnet. As for fungi, cryptococcal meningitis in HIV-infected individuals is initially treated with a combination of amphotericin B and flucytosine, followed by long-term maintenance therapy with fluconazole, which is continued for life or until the individual has a CD4-positive T-cell count of over 100 for at least 3 months. Coccidoidal meningitis is classically treated with fluconazole. However, intrathecal amphotericin B, which is injected into the subarachnoid space, is also an emerging option. Finally, in some situations, bacteria, fungi, and parasites can wall off from the rest of the brain parenchyma, forming an abscess. Brain abscesses can also develop from other infections in nearby structures, like otitis media, mastoiditis, sinusitis, or dental infections. Bacterial brain abscesses are usually polymicrobial and commonly include gram-positives like viridin streptococci and Staphylococcus aureus, gram-negatives like Klebsiella, E. coli, and anaerobes like Bacteroides species. Pathogens can also come from a hematogenous source, like dissemination from a lung abscess or endocarditis. Other causes include nocardiosis caused by nocardia, which is found in soil and usually develops in immunocompromised individuals. Individuals with nocardiosis present with tuberculosis-like symptoms, including fever, weight loss, night sweats, and pulmonary infiltrates. The presence of skin lesions and brain abscesses distinguishes it from tuberculosis. As for parasites, the tapeworm Taenia solium can cause neurocysticercosis, especially in those who have been exposed to contaminated pork. Most individuals with neurocysticercosis are either diagnosed incidentally, or they present with epileptic seizures. Uniquely, in HIV-infected individuals with a CD4-positive T-cell count of less than 100, Toxoplasma gondii can cause multiple brain abscesses. Alright, so individuals with brain abscesses can have a headache and focal neurological deficits, with or without fevers, because the infection is usually walled off, and therefore can cause less of an immune response. Additionally, there may be signs of increased intracranial pressure, such as vomiting and papilledema, as well as the Cushing triad, which includes bradycardia, irregular respiratory pattern, and hypertension. Because of the high chance of increased intracranial pressure, a lumbar puncture is always contraindicated in an individual with a brain abscess. The first step is to get a head CT or MRI, which will show a brain abscess as a ring-enhanced lesion with central necrosis. The MRI is more sensitive than CT in detecting brain abscesses, but a CT is usually easier to obtain emergently. To diagnose and treat brain abscesses, a combination of surgical drainage and antibiotics is needed. The preferred method of drainage is stereotactic aspiration, which is a CT or MRI-guided needle aspiration of the abscess. This is both diagnostic and therapeutic, because a sample can be sent off for gram stain and culture, and aspiration shrinks the abscess. Once the sample is obtained, blood cultures are obtained and empiric antibiotics are started. A common regimen includes vancomycin to cover methicillin-resistant Staphylococcus aureus and streptococci, ceftazidime to cover the gram-negatives, including Pseudomonas, and metronidazole to cover the anaerobes. Because the infection is walled off, antibiotics are given for 4 to 8 weeks. Additionally, steroids may be added if there are signs of increased intracranial pressure. Nocardiosis is classically treated with trimethoprim sulfamethoxazole, and neurocysticercosis is often treated with albendazole. Now, the approach to HIV-infected individuals with a CD4-positive T-cell count less than 100 is quite unique. Toxoplasmosis and primary central nervous system lymphoma can cause ring-enhanced lesions in this population. If there's a single ring-enhanced lesion, then the likelihood of lymphoma is high, and a brain biopsy is done. However, if there are multiple ring-enhanced lesions, then it's more likely to be toxoplasmosis. An empiric treatment with pyrimethamine and sulfadiazine is started. After 2 weeks of treatment, if there's clinical improvement, then this confirms that it was indeed toxoplasmosis and treatment is continued. However, if there's no improvement, then the diagnosis is likely lymphoma, and the lesion is biopsied to confirm that suspicion. Alright, as a quick recap. When approaching an individual with suspected meningitis, it's important to find out if there's any evidence of increased intracranial pressure, which could be a contraindication to a lumbar puncture. If not, do the lumbar puncture, then draw blood cultures and start dexamethasone and empiric antibiotics. If there are signs of increased intracranial pressure, then draw blood cultures and start dexamethasone and empiric antibiotics. Next, do a CT scan. If negative, do the lumbar puncture. Empiric antibiotic therapy includes a third-generation cephalosporin like ceftriaxone or cefotaximine and vancomycin. If the individual is an infant less than 3 months old, older than 50 years, or is immunocompromised, ampicillin should be added to cover listeria. Additionally, neonates should not be given ceftriaxone due to the risk of cholestasis. If the individual has symptoms of encephalitis, add acyclovir to cover herpes simplex. When it comes to viral meningitis or encephalitis, polymerase chain reaction, or PCR, is done to diagnose herpes simplex virus, enteroviruses, or varicella zoster virus. Cryptococcal antigen tests and India ink stain can be done to confirm cryptococcal meningitis. Acid fast smear, culture, or PCR can be done to diagnose suspected tuberculous meningitis, which is treated with rifampin, isoniazid, pyrazinamide, and either ethambutol or streptomycin for a total of at least 12 months, and steroids may be added. A venereal disease research laboratory or rapid plasma reagent test can be done to confirm suspected neurosyphilis, which is treated with intravenous penicillin G for 10 to 14 days. As for brain abscesses, stereotactic needle aspiration and prolonged antibiotic therapy is often necessary.